Girish Datar, full endoscopic management of multifocal pathology. Будь ласка.
I know it's a long day. I'll try and finish it as early as possible. Now, it is important for us to know that the pathologies that exist may not be just at one single level, or at a single level may not be just located to one place. They could be superior and inferior migrated. There could be other problems associated with that, for which we need to decide on what is the best approach full endoscopically to manage that kind of a pathology. So either it is transforaminal or interlaminar. I'm only talking about full endoscopy here. I'm not talking about the other techniques. So what are the determinants? So full endoscopic, transforaminal, the armamentarium that we have is inside out technique, the outside in technique, the outside out technique, extraforaminal and transpedicular approaches. Transpedicular usually is at 4, 5 and 5S1. Whereas the interlaminar is interlaminar, translaminar, and over the top contralateral. These are the basic accesses that we have with full endoscopic spine surgery. So what are the determinants? How do we decide on which surgery needs to be performed on a single patient? So the success of endoscopic surgery is dependent upon precise targeting of the pathology. The access to the pathology is dependent on anatomical considerations of the segment, either upper lumbar segment or lower lumbar segment, high iliac crest. All these are anatomical considerations. Location of the pathology. Where is the pathology located? Minimal collateral damage. Our surgical approach should be designed in such a way that we create minimum collateral damage. Ability and expertise of the surgeon is also important. Just theoretically thinking that I'll be able to do this may not be sufficient. Needs to be experienced in doing it. And other problems like patient factors also need to be taken into considerations. Let's see one by one a little bit before we go. So level of the pathology is important, interpedicular distance and orientation of the facet joints. These are the three anatomical considerations that need to be taken before we plan on what kind of a surgery needs to be performed on the patient. So if you look at the level of the pathology, the upper lumbar levels, these are tightly packed with neural structures, making retraction extremely difficult. So at 1, 2, you have the spinal cord itself, but lower down, the thecal sacs are very big, and then you need to be careful here. Narrower interpedicular distances, that means the distance between the two pedicle is the highest at L5S1, whereas the lowest at the L1, 2 or D12, L1. Which is again an important consideration provided you want to do a transforaminal surgery. The access and targeting of a pathology at L5S1 is much more difficult than targeting it at L1-2 or L2-3. Narrow interlaminar window in the upper levels because you have overlapping of the laminas. Vertically oriented facet joints in the upper part of the lumbar spine again makes it difficult to do an interlaminar or a translaminar decompression, where inadvertently you may destroy the facet joints. Then dysmorphic spinous process, you can see the spinous process getting tilted on one side, especially in degenerative spines, where access to the interlaminar area is again going to be extremely difficult. Advantage of upper lumbar area is going to be intervertebral foramen, which is wide. Now I have shown you the dysmorphic spinous process here, which makes sometimes difficult access within the spinal canal. Interpedicular distance, I told you, how does it make a difference? You want to target the same pathology as a central problem. See, the interpedicular distances reduces, targeting is very easy. Whereas the interpedicular distance is larger, targeting the pathology becomes extremely difficult. You need to either go more shallow or you need to do a judicious foraminotomy to gain access to the pathology. So interpedicular distance has to be taken into consideration. The last one is the orientation of the facet joint. You look at the lumbar spine, the horizontally oriented facet joints. It is very easy to perform a surgery by just little bit medial resection of the facet joint, which will not cause any kind of iatrogenic instability. But if you try to do it this way, you take off more facet and then there is a problem. Whereas in the upper lumbar spine area, look at the destruction of the inferior articular process, that will be too much. So you may have to do this transforaminal, or the best thing is, in case you want to do an interlaminar surgery in the upper lumbar spine, primarily do it over the top contralateral. So you go contralaterally and then come inside and resect part of the facet, much more safer than doing ipsilateral decompression. So a primary over the top contralateral may be a better option when it is absolutely necessary. Location of the pathology is important because some pathologies are accessible for transforaminal very easily, whereas some pathologies are extremely difficult. If you see these pathologies, which is in the spinal canal, and these pathologies in the lateral recess and in the foramen. So most of the pathologies in the spinal canal is accessible with the interlaminar or translaminar surgery, because interlaminar and translaminar surgery is surgery for the spinal canal, not for the foramen. Well, you can do an over-the-top contralateral decompression and overcome that problem. But by and large, if you see, these are meant for transforaminal and some are meant for interlaminar. Whereas over-the-top contralateral access makes it much easier, where you can do an ipsilateral decompression, you can do a contralateral over-the-top decompression of the lateral recess, foramen, and also the extraforaminal region. You can directly go underneath the exiting route, which is much easier to do it. Well, that requires a little bit of technical expertise, if one has it. So we'll discuss only 4 cases, so we understand that how we choose. So this is a 45 years male civil contractor, history of pain in the back and both thighs, 2 weeks, pain increased since last 8 days, unable to walk since 3 days, left hip flexor is grade 3, right grade 4. So this is the kind of herniation the patient has. Now let's see the tactical plan. The basic problem in this patient is, if I want to do an interlaminar surgery, because the herniation is extending not only on the one side, but it is also in the midline, it also on the contralateral side. The horizontal oriented facet joints, narrow interlaminar space, and this is a multifocal pathology, not located on the one side, but in the midline, going up and down. So this is the kind of herniation. Well, the representation that I have shown is much smaller than what actually is. So if I do this, well, possible, but there is a chance that I may destroy inadvertently the facet joint here, which may cause a problem. So a transforaminal access is a better option. Since the interpedicular distances are shorter, I can, if required, can do a foraminotomy, but if the foramen is large enough, I may not need a foraminotomy. I can do the ipsilateral decompression as well as the contralateral decompression. Now, important thing for me is to understand what is the end point of my surgery. The end point of the surgery is visualization of the ventral thecal sac. If you are able to see the ventral dura, that is the end of the surgery. So we'll just see a small clip of the surgery, how it was done. So the moment you go inside, you basically first do a intradiscal discectomy. I am half. You can see a large piece of herniation. A CT scan is necessary when you are doing an upper lumbar herniations. Most of the times these herniations are calcified or ossified. You start seeing the ventral dura. You need to do a good, see the contralateral area. You can practically see the whole element of the thecal sac from the contralateral side and the ipsilateral side. So this is the kind of decompression that you can practically do in a segment where the interpedicular distances are narrow. This is a second patient with a 42 years old male, history of pain in the left buttock and the left lower limb since 3 months, unable to walk since 3 days, difficulty in urination in 2 days. So it's cauda equina. So left EHL grade 0. So gross motor deficits, urinary retention and constipation. Now if you see the herniation, again a huge herniation, predominantly on one side, but the herniation is extending cranially as well as caudally. You see a large herniation which is going up and down. A pure transforaminal surgery may be difficult. Let us see grade 3 dorsally migrated herniations, far up and down migrated. Evidence of stenosis is there with ligamental flavum thickening. High iliac crest making us difficult to go. So if we want to plan, this is the extent of herniation which I've shown. There is no problem. At the level of the disc, no problem. I can do a transiliac entry and do it. But if I have to go up, then it is a problem. I may have to change the entire trajectory, which makes it extremely difficult for me to go ahead. So a transforaminal surgery may not be useful, that I may not be able to take off everything. An interlaminar surgery or a translaminar surgery may be good here, where the facet joints are not very much vertically oriented. I can save the part of the facet joint and do a good translaminar decompression. So this is the herniation. So once I've done a ipsilateral decompression and expose the thecal sac, the moment I retract, I start getting it out. This is at the level of the disc. So this is the part of the herniation which I'm taking off. You can see the mere size of the herniation. It's quite a bit large herniation. In herniations which are really tight, it is better always to do a more of midline decompression, take off more of base of spinous process and more of central ligamentum flavum, so that you have abundant room for retrieval of the herniated fragments. So once you have done that, then you go cranially. You know that there is a large cranially migrated herniation. So use a small nerve retractor so that you can retract. Here I'm using a stenoscope. So the possibility of going inside the spinal canal is little difficult. I may have to resect more bone to do that. Once the cranial migrated part has been removed, then I concentrate my attention caudally, which is medial to the pedicle, which is an inferior migrated part. So the first important thing here is to understand that we need to secure all the bleeders here, the Batson plexus of the veins, before we actually get this herniation out, because this herniation is not going to be small. This is a large herniation. So it is a multifragmented herniation, which is probably acute on chronic in origin. So gradually dissecting it out from the dura is important. See the mere size of the herniation. So herniation is too large for it to come out. What do? We cut the herniation into multiple small pieces. So cut it into small pieces so that you can retrieve it easily. So that makes it easy for you to remove the herniation. So cutting it small and then gradually going inside under vision completely to get the entire herniation out. More herniation. So once we remove all the herniation, I'll show you the last. This is the final we have removed. You can see nice pulsations of the thecal sac. All reperfusion of the dura is seen very well. And if you retract it, you can see a very well decompressed, completely mobile, not adherent. You've done a good annuloplasty here so that the annular on its own. Third case, this is a 71-year-old advocate, pain in the left buttock and left lower limb, 3 weeks, claudication 10 meters. SLR is 45 degrees on the left side and EHL is grade 3. If you can see, there is a multifocal pathology. There is involvement of the lateral recess on the left side. There is a small foraminal disc as well as an extraforaminal herniation with foraminal stenosis. So you have something in the lateral recess, in the foramen, and in the extraforaminal region. Now, these kind of cases are difficult because when we want to strategically plan, it's a multifocal herniation. You have a problem in the lateral recess, you have a problem in the foramen, you have a problem in the extraforaminal region. Now, if I plan a transforaminal surgery, by and large, I'll be able to take care of the foraminal and the extraforaminal component, but I'll not be able to take care of the lateral recess. The lateral recess may be left behind. Plus, the trajectory for the extraforaminal herniation is going to be steep, whereas for the lateral recess is going to be too shallow. So I may not be able to take off the complete lateral recess or decompress the lateral recess, especially the part of the lateral recess which is in the middle zone, which is medial to the pedicle. I may do it at the level of the disc, which is subarticular recess, but caudally it will be extremely difficult to do it. So extraforaminal access, if I want to go paraspinal and do an extraforaminal, I'll only be able to do the foraminal and maybe a little bit of extraforaminal. No chance of doing anything in the lateral recess. Interlaminar access, again, I'll be able to do maybe a little bit part of the foraminal component. Lateral recess, I can do it completely. but again, it's a half-hearted job. I'm not able to handle the herniation or the pathology completely. So the best option in this scenario is to go over the contralateral. Recess decompression, you can do a foraminal decompression, and you can do an extraforaminal removal of the pathology. So let's see how we do it. So we start from the right side. So first is going to be identification of the spinolaminar junction on the right side. We do a cranial laminotomy so that I have an access underneath the lamina wherein I can go ahead and find. So once I go on the contralateral side directly, I can start seeing the exiting route. And then underneath the exiting route is going to be my pathology. So this is the extraforaminal component of the herniation. This is all extraforaminal region. So you can save a lot of pars intraarticularis. You really don't have to take it off. This is the picture intraoperatively, and you can see this is the extraforaminal zone, which is more turned. This is the post-op MRI of this patient. This patient did extremely well after the surgery. And the last case that I would like to discuss is a case wherein you have a very severe stenosis. You can see there's an instability at L4-5, the very, very severe stenosis, which is bilateral. Now, in this situation, what you need to do, it's a multifocal pathology, bilateral lateral recess stenosis, thickening of the ligamentum flavum bilaterally, subluxation of the facet, evidence of instability. So I may have to probably do an ipsilateral facetectomy to cut the whole thing, decompress the whole stenosis, decompress the contralateral stenosis. If required, also do a facetectomy on the opposite side for complete decompression. So this is going to be my plan. I have to target everything. Ipsilateral, contralateral, the disc, the facet, the foramen, the extraforaminal region. So again, here we are talking about fusion. So identification of the spinolaminar junction. So the moment I identify the spinolaminar junction, this is a consistent anatomical landmark. I start taking off the bone from the cranial lamina till I see the midline split. From there, I know what is midline, and I can go cranial. Now identify the tip of the inferior articular process, and with the osteotome start taking off the tip of the inferior articular process incrementally from caudal to cranial till I reach the inferior end plate of the cranial vertebra. I leave a part of the bone, which I told you in the morning, over the exiting root intact, which is protecting the exiting root, which I will deal with it once I have done it. This is contralateral decompression. So you can use an osteotome, you can use a burr, whatever fancies you. You need to take off the whole lateral recess and confirm that you have reached the surface of the spinal canal, overshooting the traversing route on the contralateral side. You prepare the disc, you remove the whole facet, the entire inferior articular process and the horizontal component of the superior articular process, and create a corridor for your cage to go inside, because you're going to also distract the disc height. So these kind of cases usually require a large cage of size 13, 14 sometimes. So once you have done it, you size it. I normally use a cage one size bigger than, add more bone graft, getting inside and then rotate it. Because a large cage may not go in directly. It may damage too much of end plate. So it is better to go inside and then rotate the cage, which will give us a good area. And then begins the decompression of the exiting root here. If required, if you think that on the MRI and the patient symptomatology, the patient has bilateral problem, you may have to do a facetectomy on the opposite side also. Now there are two options. You can do it from this side itself, or you can make a separate incision to go from the opposite side. Idea is to decompress the whole exiting root from within the spinal canal, foramen and the extraforaminal region till the root completely dips down into the sauce. This is the final confirmation of decompression bilaterally. You have to also check into the mobility of the root. Just decompression is not sufficient, so you need to check mobility everywhere and then augment it with posterior instrumentation. So Managing multifocal pathology is tricky. Though you are equipped with the armamentarium of full endoscopic surgery with transforaminal, extraforaminal, transpedicular, translaminar, or interlaminar surgeries, sometimes you still have difficulties. You may have to opt more than one technique to take off the entire pathology. But by and large, if you plan your surgery well, depending on the patient's symptomatology and these patient's radiograms, then you'll be able to do it. So it's a neat balance between safety, wherein you want to prevent the damage of the facet joint, you want to prevent damage to the neurological structures, and you also want to reduce the surgical imprint on the patient. And the second most important thing is effectivity. Again, just safety is not sufficient. You have to be effective that the patient has to go home pain-free. Thanks a lot for your patient listening. I hope I have been able to throw some light on this. Thank you.
Thank you for a wonderful presentation. And actually ми маємо буквально для одного запитання час. We have a time for one question if you have from the auditorium.
Only one question. I'm sorry. Can you explain me how you do it? How can you insert the cage inside this space?
Okay.
Do one incision.
Yes.
Don't understand.
Yes, I will tell you how to do it. The first thing that you do is now there are two neurological structures that you need to take care of. One is the exiting route and second is the traversing route. In my situation, I don't have to bother about the exiting route because the part of the pars interarticularis and the ligamentum flavum is intact. At no point in the initial part of my surgery, I see the exiting route. The exiting route is not seen. Now that I have to worry about is only one, traversing route. How do I take care of the traversing route? I can just put a small dissector or maybe a small, large right angle retractor, semicircular right angle retractor outside the sleeve. Remove the sleeve. Outside the sleeve. With the endoscope, confirm that I am retracting the thecal sac perfectly. Hook the sleeve on the annulus. The assistant is holding it and you are just holding the depth because it should not come out.
Can you see the tip of sleeve through the endoscope?
Yes. You see it retract the thecal sac. Once you retract it, then you remove your sleeve and the endoscope. Your cage directly goes inside, you jam it inside. That's the end of it. It hardly takes 2 to 3 minutes because everything is done now.
But when you remove endoscope and using the retractor, insert the cage.
Yes. You just put the cage directly percutaneous because the distance is this much. There's another option. If you want to put a very large cage and you are scared that the disc height is completely narrow and there can be a possibility of injury, so you can just put the inserter through the working channel of the endoscope and then attach the cage on the tip. Turn the endoscope 90 degrees and go inside directly. Yes.
It's very easy to hear, but I think it's better to...
Yes. Yeah, but then you can turn the endoscope 90 degrees so that the optics is 90 degrees. You are able to see the traversing, you are able to see the cage and you are able to see the lateral part. Once the cage touches, endoscope turns and then jam it with your hand, it goes inside. But very, very large cages, like 14 size cage with a narrow disc height, you want to jack it up, I always put it, the soft part towards the nerve. And then once I reach the destination, I turn it.
I have understood the main line of your technique. That's all we need for that time.
Yeah, thank you.
Thank you for your wonderful presentation. We very appreciate your visit and your speech. Thank you.